All right, so we're just trying to gather all the basic anatomy that will be important to us, as later on we'll be discussing the pathology of what different joints, as is in what orthopedics. So the next joint we will be talking about is what the distal radioulnar joint. Now you should know that what we have two radioulnar joints. The ulna and the radius, they are joining up here. If you come down, they are still joining here. So the one down is what is known as a distal, is away from you. Okay, so the distal radioulnar joint is a key pivot point in your wrist. So it allows the forearm to be able to, twist, rotate. You understand? Okay. So that's specifically pronation. That's taking your palm down and taking your palm up, like this. What I'm doing, So it's where the distal end of the radius and the ulna meet. Meeting up is the proximal radioulnar joint, right? So for anatomy and function, articulation is between the sigmoid notch of the radius and the ulnar head. Motion enables rotation of the forearm while keeping the arm stable. So we have different stabilizers, like the triangular fibrocartilage complex. Alright. The volar and the dorsal radioulnar ligaments. Okay, this one I was looking at the proximal one. Alright, it's basically the down, because the proximal one of the stabilizing complex is annular ligaments, right? So I was looking for that. They'll have the interosseous membrane and the pronator quadratus muscle. Right, so these are all the various injuries that could occur at the distal radioulnar joint. Dislocation, teres, Galeazzi fracture, excess Lopresti injuries. All of them, will come and discuss them. Do you understand? So before we discuss them, we're just talking about the distal radioulnar joint, so that it will not sound strange at that time. So diagnosis is just physical examination. The patient is in pain. The area is swelling. The patient can't really use the area well. Also imaging, X-rays, MRI, CT scans. So treatment. So non-surgical, like they can cast the place, not move it for some while, just for the place to come up. If there's inflammation, you use non-steroidal anti-inflammatory drugs. Then physical therapy. Then surgical options. For any other thing that is basically out of hand. So that's just it about the distal radioulnar joint.